Welcome everyone to this Thrombosis Canada program, Management of Pediatric Thrombosis, focusing on current evidence. And would like to share with everyone that tonight's program is supported by an educational grant from Bayer. My name is Mihir Bhatt, and I'm one of the pediatric hematologists oncologists at McMaster University, and I will be facilitating tonight's session. Just a couple of housekeeping items to keep in mind. The system has automatically muted all participants except for the speaker. If you have a question, you're welcome to use the chat function to post it at any time during the presentation, and we'll be addressing all the questions at the end of the presentation. The facilitator, myself, will ask the question on your behalf, so I'll try to combine any questions that are similar and ask it to the speakers. Tonight's program is for 90 minutes. The initial presentation will be about 75 minutes, and then we'll have 15 minutes for questions at the end. And our speakers tonight are Dr. Anthony Chan and Dr. Suzan Williams. We just had a disclosure slide and for everyone to see from the speakers and the facilitator. And again, to remind everyone, this program has received support from Bayer in the form of an unrestricted educational grant. And also of note that the speakers and moderator are eligible for an honorarium from Thrombosis Canada. Also, Bayer benefits from the sale of a product that may be discussed in this program, Rivaroxaban. The content of this program was developed by the Planning Committee and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. And again, the speakers are Dr. Anthony Chan and Suzan Williams, and I'll be moderating myself, Mihir Bhatt. And the objectives for tonight's program are to explain advances in treatment options for pediatric thrombosis, to describe appropriate uses of anticoagulant drugs in pediatric thrombosis, and to discuss approaches to treatment decision-making in pediatric thrombosis. And it's my pleasure to introduce the first speaker, Dr. Suzan Williams. She completed her Bachelor of Science from McMaster University in Hamilton, Ontario in 1993. She completed her medical school at the University of Toronto in 1997. She completed pediatrics and pediatric hematology oncology training at McMaster University in 2003. After this, she joined full-time faculty in the pediatric hemostasis program of the hematology section in the Division of Hematology Oncology at the Hospital for Sick Children in 2003. Currently, Dr. Williams is a clinician specialist in the Department of Pediatrics and an associate professor at the University of Toronto. She has completed a Master's of Science in Health Research Methodology at McMaster University in 2006, and she has a second Master's in Hemoglobinopathy through the University College in London, United Kingdom from 2011. Dr. Williams's clinical and research interests are in the area of thrombotic disorders and sickle cell disease and stroke. She's currently the Education Training Program Director for the Sick Kids Pediatric Hematology and Oncology Fellowship Program. Welcome, Dr. Williams.
Thank you, Dr. Bhatt, for that lovely introduction. And welcome again, everyone, to our session on management of pediatric thrombosis. So before we get to the heart of the presentation, we're going to first give you some cases to consider as you're listening to the data and the literature presented by Dr. Chan. So our first case, our first clinical vignette, is a 16-year-old female who presents with 3 days of cough, parasternal chest pain, and shortness of breath. She has a past medical history that's significant for menorrhagia, for which she was commenced on a third-generation oral contraceptive agent 5 months prior. She has no other significant past medical history, and importantly, no family history of venous thromboembolic events. She has stable vitals with a little bit of tachycardia with her heart rate there. She has some tachypnea, but her oxygenation is adequate at 92 to 93%, and her blood pressure is normal. Her chest X-ray reveals an absence of any evidence of an acute cardiopulmonary process, and consequently, you suspect that this young lady has had a thrombotic event and is presenting with a pulmonary embolism. What are the treatment options and considerations that you may have? Our second clinical vignette is a 1-week-old boy who was born via spontaneous vaginal delivery at 40 weeks of gestation, following an uncomplicated pregnancy. Did have a little bit of shoulder dystocia and left clavicular fracture at birth, but was otherwise well on arrival to the world. Has had poor feeding, lethargy, and presents with left-sided focal seizures, for which his parents have brought him to the emergency room. Head imaging, specifically in the form of a CT with a venogram, reveals an extensive cerebral sinus venous thrombosis with an associated left thalamic hemorrhage. What are your treatment options and considerations in this case? And at this point, I will turn it over to Dr. Chan.
I'll take a moment to introduce our next speaker who will carry on from here, Dr. Anthony Chen. Dr. Chen is a professor of pediatrics at McMaster University, a pediatric hematologist at Hamilton Health Sciences, director of the McMaster Pediatric Thrombosis and Hemostasis Program, and holds a McMaster Children's Hospital Hamilton Health Sciences Chair in Pediatric Thrombosis and Hemostasis. He recently completed his term as Associate Chair of Research in Pediatrics and as Head of Division of Hematology Oncology in the Department of Pediatrics. Dr. Chen is a clinician scientist who runs a lab with the Thrombosis and Atherosclerosis Research Institute. He established the McMaster Developmental Hemostasis Laboratory at TARI. Dr. Chan's interests in discovery and clinical sciences encompass the realm of pediatric thrombosis and hemostasis. His inventions have led to many patents and products that have the potential to impact patients worldwide. To date, he has published over 310 peer-reviewed articles and holds 9 issued patents. Dr. Chan is the inaugural recipient of the McMaster Children's Hospital Hamilton Health Sciences Foundation Chair in Pediatric Thrombosis and Hemostasis, currently serving a second term. He was the inaugural recipient of the Maureen Andrew Canadian Pediatric Thrombosis and Hemostasis Network Award for dedication to childhood thrombosis in 2016. For his many achievements and contributions, Dr. Chan was awarded the Order of Ontario in 2017. Of note, Dr. Chan shares his expertise by providing around-the-clock consultation through free 1-800-NO-CLOT service. This service provides consultations for pediatric healthcare professionals around the world who are seeking assistance with the treatment of children with complex problems. The service is offered 24 hours a day, 7 days a week. Thank you, Dr. Chen, for presenting today.
Thank you, Mihir. I'm just trying to look at my control first. Not quite working, but anyway. Thank you for the introductions. Thank you for having me to present this topic that is dear to my heart for a reason. I'll show it to you. This is a picture taken 21 years ago. This is my son. He's now 21 years old. He was diagnosed to have a central venous line related thrombosis at that age. And in some way, he taught me about balancing risk and benefit from a patient's and family perspective. As well as, other than Jonathan taught me a whole lot about thrombosis, of course, also from my mentor, Maureen Andrew, mentioned a bit earlier. Now, I want you to read through this quote first, and I'll be silent until I get to the underlying part. So we update our opinion or diagnosis as each imperfect piece of clinical information becomes available. This is particularly important in pediatrics and especially in pediatric thrombosis because it's a relatively rare disease. And so conducting a randomized controlled trial may actually take a long time to get to therapeutic answers. And so we take a step at a time, evaluate the data, and then we improve upon it. And that's when through different trial and error and with an iterative approach. So I'd like to take a step back first, look at thrombosis. This hasn't really changed with the Werkhoff's trial. Whenever I approach a child to manage a child with a thrombotic issue, I still think about what is the risk factor for them to develop a thrombosis. It would be actually a very good start. Is it a vessel problem? Is it a stasis problem? Or is it a blood component problems? And then with the development of science, we are also reminded the inflammation is particularly important when there's an interaction between the hemostatic system and the inflammatory system, and that's when thrombosis arise. A really recent example will be COVID. It generates a lot of inflammations, and then in some way they're all prone to thrombosis as well. When I also approach thrombosis in children, I always separate them into venous or arterial thrombosis, although for today's presentation, we're focusing mostly on venous thrombosis. But let's take a look of the arterial thrombosis. You can separate for it to be above the neck, that is the arterial ischemic stroke. A lot of the arterial vascular disease are inflammatory. And of course, there are those that is related to what we have done to the patient, like inserting artificial heart valves or shunts, and then others will be related to catheter-related thrombosis. For the venous side, it's also above the neck, will be cerebral sinovenous thrombosis. For those that is below the neck, it is mostly secondary thrombosis. With catheter-related thrombosis would be actually a significant a risk factor. I'm trying to get my pointer, okay? So let's see, it doesn't work. And when we deal with thrombosis in children, it's also reasonable and important to look at whether it's from a neonate or older children. Although some of the recommendations for treatment is the same for both groups, but there is some differences that we're able to highlight with the subsequent presentations. Now, this data is basing on the Canadian registry back in 1994. In that registry, on the x-axis, that will be the age group. On the y-axis is the number of patients enrolled into the registry that actually has a thrombotic diagnosis. Obviously, for the one that is less than 1 year of age, seems to be the largest age group. However, if you actually put the teenagers together, they actually become another large age group. And then for the rest of the age range, they're pretty steady over the years. Now, you may ask, why did it drop almost like from 14 years old onward? Partly is because it's a pediatric study. I think by that age, some of these patients are already being seen by in the adult emergency room or by internist or family doctor. This data is from 2009, clearly demonstrated to us. It's from the US, that over the years from 2001 to 2007, the diagnosis of thrombotic disease in pediatric patients admitted to the hospital increases over time, and then it increased in all age group from less than 28 days to all the way up to the 18 years old. So we are dealing with, you can say, a little bit of like a epidemic, because this diagnosis, we probably generated these diagnoses because of the invasiveness of how we treat the underlying disease. Say, for example, using central venous catheter or drug that could be prothrombotic. On the other hand, we are probably getting even better in making the diagnosis. The location of these clots are actually quite of a variety. In the same report, it will show it to you is could be in the renal vein, portal vein, would be in the brain, cerebral sinovenous thrombosis. However, unfortunately, in this particular report, almost a third of them is actually in unspecified locations. Of course, there's the obvious one in the lower extremity or upper extremity, especially for those that is related to the use of the central venous catheters. In terms of the underlying conditions, you can see cancer is a significant part in this particular registry that is stated a quarter of a century ago. Almost a quarter of the patients are cancer related, okay? And then congenital heart disease mostly related with the interventions, the surgical interventions. And then there's others. What are some of those others? More recently, say for example, this is an abstract published in 2020, looking at inflammatory bowel disease in pediatric patients, clearly identify, although the VTE are relatively rare among children with IBD, they are actually at a much greater risk than children without IBD. So for gastroenterologists looking after for this particular populations, we have to be cognizant about that risk. The use of central venous catheters is again another risk factor. Again, the exact percentages may not be that important because the percentages changes depending on the populations that you are looking at. But suffice to say, in the adult thrombosis, very little number is related to the use of central venous catheters. In neonates, could be up to about 90% in this Canadian registry. And for the rest of the children, they're somewhere between the neonates and the adults. Now, this is another population study that is published from Denmark, clearly also identified the increased diagnosis of DVT in children. But in here, I would like to show you this data. This panel with the VTE diagnosis, despite the fact that in the Canadian registry, it's about 25% of the patients with the underlying diagnosis of cancer. In this particular population study, it's only about 2.7%. Similarly, for the use of central venous catheters, despite the fact that I said it, about 60% in the Canadian registry, in this particular Denmark study is only 8.1%. The most prominent one, however, is the use of oral contraceptive pills. Of course, related to in female, that is the denominator, because we will not be using oral contraceptive pills in the male. In that populations, that will be almost 80% of the VTE is related to the use of the oral contraceptive pills. Now, of course, this is again population specific. Suffice to say, these are important risk factors you would like to take into account, but the percentages of how much is being involved will vary from one geographical locations to the other, depending on the populations that you're looking at. Now, although a lot of the management recommendations you can find in CHEST guideline, the last one was published in 2012. Although this is not going to be have a new versions to it, but you can still get a lot of good information by reading this CHEST guideline. The more updated guideline is in 2018, published by the American Society of Hematology. So I'm going to go through some of those guidelines, but I also like to introduce some concept that could be very useful when we manage children with thrombosis. Now, take it as the timeline of thrombosis in neonates. Started with renal vein thrombosis. I call it prenatal, partly because about 20% of the neonatal renal vein thrombosis are in fact developed in utero. Why is that so important to recognize it? It's because by the time we make the diagnosis, maybe all the damage to the kidney is already been done, so the therapy may or may not be effective. Second, prophylaxis to prevent a neonatal renal vein thrombosis may be just a fertile job, okay? And then, in contrast, in cerebral sinovenous thrombosis, I call it the peripartum or birth trauma, because it could be related to factors that we could potentially intervene, say, for example, a birth trauma. So there may be a way that we can prevent it or predict it so that we can actually go on to therapy a bit earlier. On the other hand, because birth, I call it, it's just a one-time event. There is many small events that actually have all the star line up so that this baby develop a cerebral sinus thrombosis. All those risk factors is highly unlikely to occur again. Just like I said earlier, birth can only happen once. That's why in the CSVT in neonates, they are highly unlikely to have a recurrence. Last, and then there's the postnatal and iatrogenic. Those are, in fact, you can call it 100% preventable, provided we can actually not to use central venous catheters. Of course, this is not achievable yet. So that would be severe related DVT, portal vein thrombosis, or a line that is actually going into the right atrium to get to the right atrial thrombosis. Neonatal RVT, they actually have a mortality rate, although all the mortality rate is not related to the renal vein thrombosis. However, it does have a 3% rate of a chronic renal insufficiency or 30% of hypertensions. Okay, so the impact of the clot to the patients is significant. The question would be is any interventions is going to be helpful? At the present time, there's no randomized controlled trial to address whether anticoagulation will improve outcome. Having said that, because the outcome is actually is fairly significant, we would like to attempt to improve this renal insufficiency as well as chronic hypertension. So the recommendations at the present time is to anticoagulate neonates with renal vein thrombosis. Of course, it is a suggestion because the data is not strong, and then we have a low certainty about these recommendations. We would suggest to use thrombolysis if it becomes a life-threatening renal vein thrombosis, an example involving both renal vein as well as IVC involvement. When we get to cerebral sinovenous thrombosis, I'm going to quote you an article from 2010, but the data actually gives you a sense of how you're going to make decisions about treatment or no treatment. In this particular study, it shows that anticoagulation-related hemorrhage happens around 6%. However, if you decide not to anticoagulate, somewhere around 30% of these patients will have a thrombus propagations. And then thrombus propagations in general, we would say that possibly the patient will have a worse outcome. And then I'll also show you the conclusions. So in this particular study, we found that the safety of the anticoagulation protocols seems to be established, and then raised concerns about withholding anticoagulation therapy. So what we learned in this particular study also showed is, overall, the childhood mortality rate related to cerebral sinovenous thrombosis is somewhere around 3 to 12%, and then there's neurological deficit in 60% of these survivors. So again, the consequences of having these thrombosis is significant. That's why, despite the lack of randomized controlled trial, we may still like to propose to use anticoagulation therapy. And furthermore, in this particular study, it does show that potential increased mortality in patients that is not treated with systemic anticoagulant. So that leads to the recommendations at the present time is using anticoagulation therapy and the patient with CSVT without hemorrhage, using anticoagulation therapy even for the patient with CSVT with hemorrhage, of course, provided this hemorrhage is secondary to the CSVT, and against the use of thrombolysis in this particular situations. Now we get to severe related thrombosis, but use portal vein as thrombosis as an example. These portal vein thrombosis related to the use of umbilical venous catheter. At that time, back in 2010, there is really no recommendations being given, not even in the CHEST guideline. So Dr. Williams and I wrote this review and make suggestions to folks in terms of how we can actually approach the therapy. What we come up to is, one, you should rule out the contraindication of anticoagulation therapy. Second, the approach is to minimize anticoagulation therapy, because the outcome of portal vein thrombosis is some lobar atrophy, which we can tolerate, except there's maybe 3% of the portal vein thrombosis will lead to portal hypertension. Those are really the group that we want to prevent the clot to propagate. And also using repeat imaging to guide us, and then we should actually, of course, follow up these patients on a long-term basis. And this is actually follow a recommendation from the ISTH guidelines to suggest we should have these patients follow up for at least 5 years, partly because most of the portal hypertension, if they're going to develop, is going to develop in the first 3 years. And that leads to the recommendations at the present time is using anticoagulation therapy for occlusive PVT and no anticoagulation therapy for non-occlusive therapy, thrombus, or patient with portal hypertension with varices and bleeding. Now, in neonate, I'll come back to this age group in particular. The fact that there's no randomized controlled trial to say that anticoagulation therapy to improve outcome, so one cannot thought not to anticoagulate, especially if one deemed the risk of bleeding is significant. Having said that, if one decides not to anticoagulate, it is very important to have repeat imaging to ensure no propagations of the clot. Now, of course, the recommendations at the present time for these clots is by and large is to anticoagulate them unless there is some other circumstances in here like the non-occlusive thrombus in the portal vein. Then how about the more, you can say, garden variety of lower limb DVT, because that's what we encounter in adults, or in, as I alluded to earlier, severe related thrombosis a lot of times happen to the upper limb. What is the outcome that may actually guide us to how aggressive we treat this DVT? So I'm going to present to you two paper from the same group on PTS, post-thrombotic syndrome, on the lower limb DVT as well as upper limb DVT. So this is a curve to show you the post-thrombotic syndrome 3 survival curves. On the top curve here, it shows the neonate that is with line-related thrombosis. So in some way, you can say neonate with line-related thrombosis has a much lower risk of developing post-thrombotic syndrome. For the older children with line-related clot, the risk of getting post-thrombotic syndrome is in fact higher. The highest risk group will be the non-line related thrombosis patients. So in some way, one can argue if you actually have a line-related thrombi in the neonate and you can actually remove that line, maybe you don't need to anticoagulate them because the risk of getting post-thrombotic syndrome is low. And let's see later on what the current recommendation is going to be. When we actually look at the modified Villatta score to gauge post-thrombotic syndrome, with one usually is the threshold to say that they may have a clinically significant post-thrombotic syndrome. Clearly, you can say over a period of time to track the neonate with line-related thrombosis, they are pretty steady in terms of the score. And for the neonates, they always have a score almost below 1. Now, having said that, I'm not saying that there will be no clinically significant line-related clot thrombosis in neonate. In fact, the first case report to demonstrate compression stocking is effective in treating post-thrombotic syndrome is in the neonate that developed a line-related clot, is published by Dr. Williams. Okay. So the conclusion from this study is line-related lower limb DVT had more benign outcomes than non-line-related DVT. Gender in here is male. DVT triggering event in here, that would be a non-line related triggering event. And the DVT resolution would, or non-resolution for that matter, predict lower limb PTS in this particular cohort. In the upper limb thrombosis, the outcome, I would say, is fairly similar. Again, the secondary DVT in the upper limbs related to central venous line has a much better outcome comparing to the primary upper limb thrombosis that is non-line related in terms of the PTS perspective. The survival analysis also showed PTS score of more than or equal to 1 would differs amongst the group. And so the 1 score is actually fairly significant. So lead to the recommendations about the DVT is for symptomatic, the DVT and primary emboli is strongly recommended anticoagulation therapy. I would say that is a foregone conclusion. We kind of figured that would be the case. However, for asymptomatic DVT, one can decide whether to anticoagulate or not. Although I do tend to anticoagulate them, especially the risk factor has not been removed, or in asymptomatic clot somehow in the locations that could potentially cause significant complications. But the current recommendations, you can in fact do either. In terms of primary embolism, I would go, Dr. Williams will actually go through a little bit of the recommendations a little bit later, but suffice to say, thrombolysis followed by anticoagulation therapy is recommended for primary embolism with hemodynamic compromised patient. If you're still not clear about how to make the decisions, maybe what I'll do is give you a traffic light approach, kind of have a sense of what it is, but without going to be risk specific, and then you're going to apply that sort of concept into your day-to-day practice. One, when it's red, I call it dangerous. Whenever it's dangerous, we tend to be more aggressive with the therapy. Some of it is obvious. Say, for example, arterial thrombosis with impending ischemia to the limb, or bilateral renal vein thrombosis with IVC involvement, because those clots will have significant consequences. Clearly, one would like to anticoagulating them or even doing thrombolysis. Maybe less dangerous, I use the amber or yellow, is symptomatic CVL thrombosis, and you cannot remove the CVL, which means the clot is already causing symptoms. You cannot remove the risk factor, so there's a good chance the clot will progress if you don't anticoagulate this patient. Last but not the least, I will put it in the green category, is the consequences of the clot may not be significant at all, like a non-occlusive left portal vein thrombosis or a asymptomatic CVL-related thrombosis with the CVL that you can remove at the time. So that is the category you can consider or at least contemplate not to anticoagulate. But again, if you decide not to anticoagulate a patient with a blood clot, it is still fairly important to follow them to make sure that they do not progress. Now, what anticoagulant to be used? Let me remind you, this is almost the first case reports to use of low molecular heparin in treatment of a neonate back in 1995. And then in the subsequent year, you can say the dosing recommendations that we use to use low molecular heparin in treating children come from this study. But I'd like to remind you, at that study, only 9 out of the 25 patients reported are neonates. So the dosing recommendation at the present time was based on the data from 9 neonates, okay? And then there's also a reason I mentioned that, and it will be clear to you a little bit later. How about the use of the DOACs, okay? This is a statement that I made about 2 years ago. Controlled clinical trials needs to be performed in children before any recommendations can be made, and we should refrain from using new anticoagulant until clinical trials is done and in situations with no alternative. And this is probably the first case report of using DOACs in pediatrics. But this is the patients treated with Rivaroxaban in severe protein S deficiency. When they try other alternatives, it's just not working. This is actually in 2013, okay, 8 years ago. This is actually from the ASH guidelines. Essentially what it's saying is, again, the guideline when it's written is a priori, is we're not going to address it, partly because there is no published data, although there are ongoing clinical trials. Now, turn the clock further. The first phase 3 randomized controlled trial has been published, and in fact, Rivaroxaban has got approval by Health Canada as well as in the European Union for it to be used in children. So let's go through this data briefly. First, I'd like to show you is the dose exposure response, really to illustrate to you how the dose is being established, and then the dosing variability compared to in adults. Because in adults, there's a single dosing regimen, and you use it for all adults. So in this publication, what it's actually about is, it's about a collection of 335 children allocated to Rivaroxaban, and they were evaluated for pharmacokinetics. And what it's actually showed is, with the dose that is being derived, and the dose is derived initially by modeling. So we model how we can get to a certain drug concentrations. We test it in the phase 1 study, and then after the phase 1 study, we establish the dose. And then when we do the phase 3 study, we look at the, again, confirm that pharmacokinetic profile. So the dosing regimens that we established will achieve a similar sort of Rivaroxaban exposure comparing to the adults. And then furthermore, it also demonstrated, other than using the tablet that is already established in adults, as some of the tablets anyway, the company also developed a suspension formulations to be used in children. And then the absorptions and the drug exposures using both formulations is actually compatible. Now, I would like to show you, though, this is not a one-size-fits-all. It's for obvious reason, because depending on the body weight, the doses changes, right? It's only when it's up to 12 kilogram, down to 12 kilogram and below, they actually have to require a 3 times a day dosing, TID. For the less than 30 kilogram, from 12 to less than 30 kilogram, is still a twice a day dosing. It's only until they're above 30 kilogram, it's a once a day dosing. For some of them would be 15 milligram, for other would be 20 milligram. So it's very important for us to be familiarized with the dosing. It's not the same as in adult. Now, this is the randomized controlled trial phase 3 study. So it's a multi-center parallel group open label study. It's involving 107 pediatric hospitals in 28 countries, okay? The first thing you have to remember is, in treatment of DVT in adults, they started the therapy with a loading dose of Rivaroxaban followed by a lower dose. In the pediatric study, all the patients started with standard of care, which is either heparin, low-molecular heparin, or fundoperidone. It's only after about 5 to 10 days of the therapy, they will be switched to Rivaroxaban. That is very important to remember, because this is how the data being derived, okay? The primary outcome is symptomatic recurrent VTE, and then we also use the repeated imaging to look at the clot burden to see if we can get a surrogate marker to suggest the effective efficacy of the therapy. The phase 3 study was conducted from 2014 to 2018. But mind you, the Einstein Junior programs started back in 2008 when the group of the sponsor and the group of thrombosis consultant was designing this particular study, including both the phase 1, phase 2, and phase 3 study. The median follow-up period is about 91 days, and the treatment period is 3 months for the older children, 1 month for the neonates. And I would like to show you in the phase 3 study, for the younger children that is less than 2 years of age, there are only about 37 neonates, comparing to a much larger group of patients that is older. The result is like this. Symptomatic recurrent VTE is only 1% in the Rivaroxaban group, 3% in the standard anticoagulant group is not superior, but at least it's comparable. And again, the recurrence rate is actually fairly low. If you go by using imaging, there seems to be improved effect of Rivaroxaban in decreasing the thrombotic burden comparing to the standard of care, and that's the p-value. In terms of the bleeding complications, in Rivaroxaban, it's about 3%, but all non-major bleeding, and then it's not different from the standard of care arm, which is 2% bleeding risk, with about 2 major bleeding and 1 non-major bleeding. So I think from the conclusions of this study is the absolute and relative efficacy and safety from the Rivaroxaban versus standard of care, they were fairly similar to what has been achieved with the in the Rivaroxaban trials in adults. Okay. And this particular study and the development also provide a formulation that is being studied. Unlike, say, for example, in using Coumadin or warfarin for that matter. Warfarin is only available in tablet form. When we actually come to a solutions, it's all compounded by compound pharmacy. So it's not well studied nor well regulated. So in conclusion for this trial, children with acute VTE treatment with Rivaroxaban will result in similar low recurrent risk and reduced thrombotic burden. And based on this study and the other PK study, phase 1/2 study, Rivaroxaban obtained a Health Canada approval for it to be used in children for specific indications, and I'll go through that a little bit later. There's also a sub-study that is published in the safety and efficacy in pediatric cerebral venous thrombosis, cerebral sinovenous thrombosis. I just go to the result. It does lead to a clinical relevant bleeding in 5 patients, which is 6.8%, all non-major in the Rivaroxaban recipients. And these non-major bleedings are not cerebral bleeding, okay? And maybe, and then in the standard of care group, it's 1% bleeding, 2.5%, and then there's a 4.4% absolute difference between the bleeding complications. Again, the recognition rate, I would call it, is fairly similar comparing to the Rivaroxaban arm to the standard of care arms. One can say maybe slightly better with Rivaroxaban, but I won't hang my hat on it, partly because it's a very limited sample size. Now, I also want to address this limited sample size in the next study that I'm going to present to you. This is a retrospective study where we were looking at the feasibility of enrolling children that is less than 2 years of age into this trial. It is an effort by 12 institutions. It's a retrospective study looking at the children that is diagnosed with thrombosis, and then going through the exclusion criteria and the inclusion criteria to see how many of these patients will be eligible for enrollment into this clinical trial in Einstein Junior. Interesting result as well. In these 346 children from the 12 institutions, more than 2/3 of these patients are against central venous line related thrombosis, confirming central venous line is in fact a significant risk factor of thrombosis in children. So I want you to look at the top line. Total number of children is 101. By the time we go through all the exclusion criteria, the potential eligible patients is only 12 patients. So there's a limited subset of patients we actually have performed the study on. Now, I also want to point out to you in the, these are indications for Rivaroxaban in adults. There are a variety of indications that actually has not been studied in children. Some of them probably is not relevant, but they also come with varying dosing regimens. And however, what we have studied is a particular indications, a particular dosing regimen. So we have to be mindful, even when the drug is being approved. Again, the dose actually vary with the weight, and the frequency also varies, ranging from TID to once a day dosing that is similar to adults. Now, I'm going to give you 4 statements about Rivaroxaban. These are all from the product monograph. Okay, and it's very important to read them because I think we should adhere to the product monograph because that is really what has been accepted by the regulator. Safety and efficacy of Rivaroxaban of 2.5 milligram and 10 milligram film-coated tablets has not been tested. It's Rivaroxaban, but the formulation has not been tested, so this is recommended not to be used in children. And then in children that is less than 18 years of age, the safety and efficacy of Rivaroxaban has not been established for other indications. It only has been established in venous thromboembolism and the preventions of the recurrence, which means this should be the only indications that you use with Rivaroxaban in children. There's limited data in the CSVT, and so you have to be cautious in terms of whether you're going to use it or not, and then you have to evaluate before and during the therapy. And this is in particular in those who have a central nervous system infection, because it seems to be impose an extra risk of bleeding. Coming down to the age, I think this is very important to remember and adhere to. Dosing of Rivaroxaban cannot be reliably determined, and because it was not studied in children less than 6 months of age who are also born less than 37 weeks, body weight less than 2.6 kilogram, or they have not established oral feed for at least 10 days. So one has to remember these very well, partly because we don't tend to going to evaluate the Rivaroxaban level, and there's never a really clinical correlation. We know where the drug level is, but we are not going to evaluate them, and it will be a lot harder to adjust dosing. So this actually should be remembered. Last but not the least is, and Dr. Williams is going to address management of heavy menstrual bleeding on anticoagulant, because a lot of these patients would be teenagers, possibly had the DVT and PE secondary to use the oral contraceptive pills. In this particular trial, however, this is actually for women that is older than 18 years of age. There is some suggestions with Rivaroxaban would actually increase incidence of uterine bleeding comparing to other anticoagulants. Okay, this is the line for Rivaroxaban. This is for the dabigatran. However, this is for more than 18 years of age, but that is something to be mindful of. So in conclusions, I would say there's much advances in the understanding of pediatric thrombosis, albeit it takes us a long time. Rivaroxaban is the first anticoagulant approved for use in children in Canada, and it shall be used according to the regimens in the clinical trial, which is the first phase has to be the standard of care, which is low molecular heparin, or fundamental Paranox, because we come with the most experience in those trials, and then subsequently switch to Rivaroxaban. And please check the product monograph. And again, if you use it, if you can afford it, do participate in the post-marketing surveillance program, because that we can actually assure safety and efficacy. And then there's still other DOACs clinical trial for different indications, and it's fairly important for us to continue to participate. Now, I'd like to thank all of you, and this is how you can find me, and then I'll pass on the presentations to Dr. Williams now.
So if we return back to our cases and using some of the information that Dr. Chan has gone through in terms of the evidence and the approaches one would have, we have a, if we go back to our first case, oh, sorry, I've just lost control. Let me do that again. So our first young lady was the adolescent who had a symptomatic pulmonary embolism on presentation. So she has symptoms, so she qualifies as symptomatic, and she does not have cardiovascular instability. She has a normal blood pressure, so she has a non-massive pulmonary embolism, although she does have some tachycardia and tachypnea. our management targets for a thrombotic event are really quite broad, as Dr. Chan has talked about. So the first arrow is the items that you'd want to do, if possible, in almost all patients that are presenting with a thrombotic event. So treating or removing the risk factor that predisposed to the formation of the clot, reducing the thrombus progression in some cases, and in extreme cases, to actually attempt to recanalize the vessel that has the clot. So if we focus on targeting the clot for a moment, our antithrombotic agents would come in here, which would largely be anticoagulants, sometimes antiplatelets, but the heparins, the low molecular weight unfractionated, vitamin K antagonists, and now the direct oral anticoagulants. Thrombolytic agents and thrombectomy, as Dr. Chan has already described, would be reserved for those red light or those extreme situations. So highlighting again the ASH recommendations that would be pertinent to this young lady. She has a symptomatic PE, and so anticoagulation per the ASH guideline would be recommended for her. Her PE is not submassive, and so there would be a recommendation or suggestion against thrombolysis for her, similar for thrombectomy or inferior vena cava filter. So the options of medications, if we look at the traditional medications, unfractionated heparin, low molecular weight heparin, the vitamin K antagonists, and now the direct oral anticoagulants, looking at their mechanism of actions, administrations, half-life, excretion, lab monitoring. And the big advantage, of course, of the DOACs is the absence of need for lab monitoring. We do have antidotes available for some of them, but that is to be kept in perspective of the availability and the cost of those antidotes as well. The other big advantage is supposed to be the overall similar or decreased bleeding risk, but we do know that there is a signal of increased GI bleeding with these. And then the other rare or less common side effects that you can see, each agent will have those that are unique to it, such as a HIT or heparin-induced thrombocytopenia with unfractionated or standard heparin and low molecular weight heparin, unusual things like hair loss and tracheal calcifications with the vitamin K antagonist, and increased rates of GI disorders and rare liver injuries that has been reported with use of the DOACs. So we've already touched on the advantages and relative disadvantages. So unfractionated is an intravenous medication, so really not appropriate for your outpatient use, but for a hospitalized patient, short half-life, and you can reverse very easily. The low molecular heparins, easy to administer, stable, are renally cleared. Warfarin, very cheap, but very potentially problematic in terms of monitoring, dependent on the other comorbidities or other medications that a patient may be on. But again, you have a reversible agent. And now this slide was from a manuscript back in 2017. So this line should now have a big red line through it that there is a direct oral anticoagulant that is approved for patients under 18. And you can see that the advantages are similar, that there's at least a couple for the DOACs and seemingly fewer potential disadvantages. But as Dr. Chan has pointed out, there are still some disadvantages. So if we talk about what the treatment options would be for PE in general, for initial therapy with low risk of bleeding across the board, whether it was provoked, idiopathic, or recurrent, the tendency would be to go with low molecular weight heparin. If there was a high risk of bleeding, you'd want to take advantage of the reversibility of using an unfractionated heparin product. And subsequent therapy after initial therapy would flip over to either the low molecular weight heparin or vitamin K antagonist. We tend not to use the vitamin K antagonist so much in infants in our center, but it is an option. And for older children, again, the traditional agents of the low molecular weight heparin, the vitamin K antagonist, and now potentially the DOACs could be introduced here, with your duration being in the provoked instance, 6 weeks to 3 months, in the idiopathic 6 to 12 months, and extended therapy once you've presented with recurrent. So this is a table looking at abnormal uterine bleeding rates in adult studies of Rivaroxaban and Apixaban for the treatment of VTE. So the rates of abnormal uterine bleeding that were seen with Rivaroxaban from a number of the randomized trials ranges from 0.8% to as high as 50%. Again, varying with the dose that was used, lower dose here, higher dose here, and the population which was treated. In this one, patients with VTE. In this one, it happened to be patients with VTE who had sickle cell disease, who seemed to have a higher rate of bleeding with the DOACs. If we look at the abnormal uterine bleeding rates in pediatric studies of Rivaroxaban for treatment of venous thromboembolic events, the numbers look even higher than those which appeared on the slide prior for the adult studies. So ranging anywhere from 7% to up to 15 to 19% compared to 7% for the more traditional anticoagulant agents. So this really does highlight that although the drug is approved, it may or may not be the right or most appropriate choice for your patient that's presenting before you. The evidence-based guideline for use of oral anticoagulation in menstruating women is if there's when there's an indication for oral anticoagulation therapy, you need to take a menstrual history both before and after the initiation of anticoagulation. If there's ongoing consequences of the uterine bleeding, then Apixaban would be the first-line oral anticoagulant recommended over Rivaroxaban. And similarly, even if you had control of the abnormal uterine bleeding or it wasn't an ongoing issue, again, Apixaban over Rivaroxaban would be recommended as your first-line agent. So in our patient who is an adolescent, is 16, would be in the dosing category that she would be able to go to once a day dosing at some point. Still, if we're following the trial recommendations, she would start anticoagulation with unfractionated or low molecular heparin with consideration for Rivaroxaban probably not being ideal for her given her history of abnormal uterine bleeding because she was started on the oral contraceptives for menorrhagia. If we go to our second case, this was the newborn infant who's a week old and presenting with symptomatic cerebral sinus venous thrombosis with concurrent hemorrhage. So again, the targets for your management would be to treat or remove the risk factor that predisposed to clot formation if you can, hopefully protect the brain from the ill effects of the venous congestion that is now being experienced, and in extreme circumstances, attempt to recanalize the clot and alleviate that venous congestion directly. When targeting the clot, the approaches would be the same as what was described for the young lady with the PE. And again, highlighting what Anthony discussed in regards to the ASH guidelines for cerebral sinus venous thrombosis in children is that even in patients with concurrent hemorrhage, the suggestion would be to anticoagulate. And we would suggest against thrombolysis in the vast majority of patients. So these recommendations are based on randomized trials in adult CSVT and the pediatric cohort studies of which Anthony described, which have highlighted that anticoagulation therapy in CSVT in children reduces the risk of severe neurological deficit or death, reduces mortality, reduces recurrent VTE, reduces thrombus propagation on imaging done at 2 weeks, and has an acceptable intracranial bleeding rates in the range of 0 to 6%, as you've already heard. So a complication rate, when we look at anticoagulants and outcomes in CSVT, 5% with no mortality, that even when you have hemorrhage in selected cases, that it would still be appropriate to anticoagulate, because if you don't anticoagulate, the propagation rate is 35%. The risk of a brain injury in the setting of that propagation is 40%. Neonates recanalize faster, and the clinical outcome is worse in newborns than in children. So again, highlighting why one would want to really have a good reason not to anticoagulate, knowing that the outcome can be significant in terms of morbidity. And the recurrence of CSVT is much more significant in older children compared to neonates. So some of the challenges, controversies, and decision-making for a case like this, where you have a major hemorrhage event presenting at the time of your very significant thrombotic event, is how significant is that hemorrhage, and how significant in comparison is your clot? What are the comorbidities that could increase your risk of bleeding, and the baseline clinical condition of the patient? That will all help you formulate your initial decision with the evidence that I already shared about introducing anticoagulation at presentation. And similarly, this whole process of the decision-making being dynamic, on follow-up, you're still going through similar thought processing. So has the intracranial hemorrhage stabilized? Is it worsening? Is it improving? Has the thrombus stabilized? Is it propagating or recanalizing? And the clinical condition of your patient will factor in again to the decision-making about initiating, as we talked about in the first box, and continuing or withholding anticoagulation, dependent on the information that your patient is subsequently providing to you. An important point in regards to intracranial hemorrhage in the setting of cerebral sinus venous thrombosis is that one may actually potentially expect to see some intracranial hemorrhage in these patients, given that there is this venous congestion, and you may actually improve the bleeding by relieving that congestion. So paradoxical improvement of the hemorrhage by putting your patient on an anticoagulant agent. So the Einstein Jr. cerebral sinus venous thrombus study Anthony has gone through. Importantly, the Rivaroxaban had fewer recurrence than the standard anticoagulation. The bleeding was a little bit higher, but again, deemed acceptable. The limitations to the data, as has already been described, is that it was a subgroup analysis. The trial was not powered to look for differences in particular for this subgroup. It was open label. There were actually a low number of term neonates and infants enrolled. And this goes back to the point that Dr. Chan had at the beginning in regards to making sweeping treatment recommendations based on very small cohort of patients that have been studied. This cohort may represent a less ill population than prior studies, as it was the investigator potentially enrolling a select proportion of the patients at their center. And there were asymptomatic patients that were included as well, and whether this would alter the outcome in patients if it was just symptomatic patients that were included. The outcomes were evaluated at 3 months, but as was mentioned, often in CSVT treatment, your treatment duration is longer. So even if we made this baby for simplicity a term greater than the 2.6 kilos, so say he's 3 kilos as a term infant, he presented at a week, so hasn't had 10 days of oral feeding. If he's unwell and having seizures, he may not go on to feed immediately. And he would still need upfront of a traditional anticoagulant and fractionated or low molecular heparin before you would even consider possibly a DOAC if you actually had access to the suspension form of the Rivaroxaban and felt that compliance would be reasonable with a TID dosing in a small infant. So again, although the agent is available and has been potentially licensed for use in this population, it may not be the practical choice for this infant. And at that, I will end the official part of the presentation and say thank you to everyone for staying and listening, and I'll turn it back over to our moderator, Dr. Bhatt.
Thank you, Dr. Williams and Dr. Chan. Okay, so we'll take questions now. So it will be great if people can write questions in the chat. We have a couple already. So I will ask the first question from Karen Moffat. Due to variability in the dosing in children, do you suggest or do you think that anti-10A-led monitoring for Rivaroxaban would be required?
Dr. Chan, do you want to go ahead and answer?
Yeah. I think at the initial use of a clinical use, I think it would be helpful for us to check the level. Mostly is to confirm what is being done in the clinical trials. The reason I still like to confirm that is especially the younger children's, because it's a limited data set, you can call it. For the older one, if you ask me, say for example, their adult size, adult age, and there's a whole lot more data in the adults. Now, mind you, the data set that is being used for approval in adults, even for the treatment of VTE, the median age of those patients are in the 50s and the 60s. They're not the young adults. But having said that, I think there is, at least for the initial use of it, checking a level, not really to adjust the dose, because I think it's a lot harder to adjust dosing in the oral medications based on the drug, but at least get a good sense. Yeah, I think we confirm what is being done in the trial. Maybe even more important for the young ones, even those that actually fit into what is in the product monograph. It's 37 weeks and more than 2.6 kilogram and more than 10 days of feeding. I think for the, at least for me in the clinical practice, and Karen is from McMaster, of course, I would do those levels so I can actually familiarize myself. But after maybe some of these patients, I will stop checking them. Like when I get a bit of reassurance, whatever I see clinically is similar to what is in the trial within the range of the rivaroxaban level that is being seen in the PK analysis, then I will stop doing them. The trick here question is, how are you going to move down at the age? Because the younger they are, the less you like to do the injection, right? Like the site for injection is a bit low. How do we actually get down to that age? I think, again, we probably need some more information for the youngest cohort first before you can even move down on the on those smaller babies. So the short answer is, I would like to check that level, but not forever. The reason I checked it is confirm what we see in the clinical trials. That become particularly important for the younger patients.
Thank you. We have one more question from Sakara Hutzpardel. Please pardon my pronunciation. Is there any evidence of antidote for DOAC use in children? I presume in cases of bleeding on DOAC. And would that point, or should that point be taken into account before using DOAC in children?
Yeah, so I think that's a great question. I mean, the only antidote that has been studied in the pediatric trials would be for dabigatran, and not the andexanet alpha, which would be for the Rivaroxaban. So the only agent that's currently licensed is the Rivaroxaban. We don't actually have access to andexanet alpha in Canada. So if you were going to choose a DOAC based on the availability of an antidote, you would be choosing to use one that's off-label at this point. So I don't think that's a real factor in making the decision, given that you, again, would be outside the spectrum of on-label use. I don't know what Anthony's thoughts are.
Yeah, maybe I'll talk about the on-label use. I think it's very important to use this new drug on-label, because that partly we learned from the lesson, even the dose of low molecular heparin, right? Like it was based on 9 babies. It takes about another 10 years for us to figure we probably need a higher dose. But one that is set in, we can't even change it, or there's reluctance to change it. And so I think sticking with the label is very important. And then if you want to move outside of the label, it is one is truly a need that is not met by the current medications that is available, and second, possibly in a clinical trial. And then in the reversal, no matter what, I don't think we are going to get a whole lot of data in terms of the reversing the reversal agents, be it available or not available in Canada. So in some way, like if you're going to use it in the babies, that is a risk, and so you have to assess that risk. That risk in some way is unknown. Having said that, maybe the good part of it is it's a TID dosing, which means the drug is going to be out of the system a lot faster, which means as long as you have a good sense of what is actually happening to the baby, that risk may not really be as huge. I'm not saying that like there's no risk, but that risk may actually not as huge as we thought, as long as you can ride it out for 8 hours. Yeah.
Thank you. One more question from Nathan Han, which is following up on the question about monitoring. So the question is it the case that performing an anti-10A level, it can only show you if there is therapeutic effect or not, but one cannot adjust a dose of Rivaroxaban like you would in a low molecular weight heparin? Is that accurate?
Suzanne, you want me to take this one?
Yeah, go ahead.
Okay. There is really no, like say for example, in warfarin and unfractionated heparin, low molecular heparin, they are all protocols that guide us to adjust dosing. So it has been studied. In here, there is no guidance whatsoever that I can give you. And then I think it's a lot harder to guide because it goes through the gut and the absorptions. You don't even know what factors actually going to make a difference. And that's why I actually say I'm not so sure I would know how to adjust the dose based on the level. The level for me is really, yeah, I think I got the level of what is being studied in the trial. And that kind of correlate, you can say, really similar to the adult. And then by looking at the clinical outcome in the pediatric trial and the adult trials, it seems that if we get a level like this, we will get a similar sort of outcome. But adjusting it, I think is going to be difficult until maybe we got in time is we should design a trial, especially when we get to the younger ones, especially those PRAMs. The problem with the PRAMs I learned is even we are not even sure how the development of the gut in terms of absorptions to the drug. So if the babies develop in utero, could be different when they develop after they were born, which means even if they get to after birth, get to a gestational age of 37 weeks, it may not be the same as a baby born at 37 weeks. So that I think will take a lot more thoughts and investigations if we are going to move down that age group, and then maybe have to, not maybe, then we have to study how we potentially can dose adjust it. Now, of course, you can still dose adjust it, partly because there is a suspension, right? It's not a tablets. Tablets is a lot harder because they're study on looking at coumadin. When you split the tablets, the variability of dosing can be up to about 30%, depending on the type of tablets that you use, comparing to dissolving a tablet of warfarin and then incrementally drop the volume. The variability is about 10%. And this study is actually even fairly recent. So I think at the present time, it would be hard to know how to adjust the dose, even if I get a level.
Again, following up on a question about bleeding, do you have a protocol in place in your hospital for treatment of a bleed on Rivaroxaban? Or I'll extend that question to say, even if you don't have a protocol, how would you approach a patient who has a bleed on Rivaroxaban?
Hey, Dr. Bhatt, why don't you go for that question?
It sounds like something we probably need to do to develop one. We don't have an in-house one developed yet either, but that clearly is, would be an unmet need that one would need to develop that if we're going to be seeing more and more patients presenting on with use of these agents.
Yeah, maybe I'll jump in as well. So Mihir and I and the team is really, you can say, developing a standard within our team so that to be sure we're consistently, say for example, there's some patients that is on VTE prophylaxis, like these long-term treatment patients. So exactly, we will set up a standard in terms of what we will do, how we'll follow them when we switch them over. And I think in the same vein is we probably would do it as a concerted effort to work with the others pediatric centers across the country to be sure we actually establish a very similar approach. So when we actually go back and look at our data, we can make some sense of what we do. So the answer is there's no such protocol, but we are developing it. And I think the approach is, say for example, before the antidote was actually published or studied and approved, I was actually involved in writing a review as how to handle these patients with bleeding. Okay, then it depends on the situation, depending on your philosophy. One of the arguments is actually, I call it a therapeutic nihilist, in a sense that, hey, nothing proves to be useful, then you shouldn't do anything other than being supportive, like maybe using charcoal to absorb the drug if it is an overdose, or maybe if it is dialysable, you dialyze the patients, but nothing more than that. Because at that time, the suggestions of using 3-component PCC, or recombinant 7A, or even the activated proteins, the bypassing agents, those I'm not sure I would actually use, but those are actually being talked about before those reagents are being developed. But we are not really in a very different state. The drug is being developed, but we have no dosing strategy, and again, it's not approved in pediatrics. Then I would say maybe it's really an observational approach, and maybe even I started earlier is really making sure the patient that you're going to put on it, and then also maybe further explain to the patients and the parents. There's a certain amount of uncertainty or risk there, and that they would accept, although the drug is approved. And I think there's a lot of data, especially for the indications. I think I'm confident in using it, but there is still something that I think we should be aware of.
And I guess, one small comment I would like to make is the anticoagulant that you likely most commonly used in pediatrics right now, low molecular weight heparin, it also does not have a complete antidote. Protamine sulfate can reverse it about 50 or 60% of it, but it doesn't have a full antidote, like unfractionated heparin or warfarin, for example. One question from Rebecca Goldsmith. When we're discussing about Rivaroxaban levels, is there an optimal timing for testing that you would suggest to be able to compare it with sort of adult exposure time?
I'll let Anthony take that one since he's the one suggesting we should all do levels.
So so Rebecca is actually from is the nurse from McMaster, and then Mihir is from McMaster. So we're actually in the middle of making these things up. So what we actually go by is we actually have these PK graph that is actually stick onto our wall. So if I remember properly, and double check on it, and then maybe I'll post an error or a posting if I'm in error. I think by the time you take a level somewhere between 1 to 2 hours, you get a pretty good sense of what, because I think that is where the PK is being done. So yeah, I think that's what we do, right? As I said earlier, we did set up a protocol, we did check the level, and I think that's why Rebecca asked that question, because we did check the level in the last little while for a couple of patients already. Those are teenagers, and the level do fits into the PK profile that is being reported.
Okay, wonderful. Any last minute questions from anyone else? Otherwise, we'll go on and conclude. Great. Well, I would like to thank all the participants for attending, and to Dr. Williams and Dr. Chan for presenting today on such an important topic. So on behalf of Thrombosis Canada, thank you once again to you and to all the attendees. And also would like to thank Bayer for the unrestricted grant, which had made this session possible.